First, I would like to welcome everyone to our Group 7 presentation. It's my pleasure to present to you today. My name is Phương and I'm excited to discuss our topic of combined nivolumab and ipilimumab or monotherapy in untreated melanoma. Before we begin, here's a task assignment table for Group 7 member. Each member was responsible for preparing their own content and slide. I'm pleased to say that all members have successfully completed their task. Our group presentation is divided into 4 sessions. Let's start with the first part, introduction. So, what is melanoma? It is a form of cancer that begins in melanocyte and it can start in the mole or other pigmented tissues. In this presentation, we will focus on 2 main drugs. First, ipilimumab. It is an anti-CTLA-4 antibody and is the first drug to demonstrate improved overall survival in phase 3 trials for metastatic melanoma. However, its response rates were relatively low, with only 10 to 15% of patients, around 20%, achieving long-term survival. Following next, we have nivolumab, an anti-PD-1 antibody, approved by FDA in 2014 and showed better response rate and longer lasting effect compared to chemotherapy. Earlier studies show that combining nivolumab and ipilimumab leads to higher response rate compared to ipilimumab alone, though with increased side effects. This brings us to the CheckMate 067 trial. It was a phase 3 randomized double-blind study designed to compare nivolumab alone, the combination of nivolumab and ipilimumab, and ipilimumab alone in patients with previously untreated metastatic melanoma. Now, let's move on to the second part of the presentation, methods. Patient selection. Eligible patients have stage 3 or stage 4 melanoma and have not received prior systematic treatment. They also have to meet all the requirements, just as they have to be 18 years old or older, have an OCOG performance score of 0 or 1, have measurable disease, confirmed CT or MRI scans, provide tumor sample to assess PD-L1 status, have a known BRAF mutation status. However, patients were excluded if they had an ECOG score of 2 or higher, had active brain metastasis, ocular melanoma, or autoimmune disease. Now, let's move on to the next slide, study design and treatment. Patients were randomly assigned to one of the 3 groups in a 1:1 ratio and received one of the following regimens. The first treatment group received nivolumab alone. The second group, a combination of nivolumab and ipilimumab, followed by nivolumab. The last group received ipilimumab alone with specific dosing schedule of each regimen. All treatments were given intravenously and patients continued treatment until their disease progressed, they had unaccepted side effects, they chose to withdraw. Patients could continue treatment after progression if they were still benefiting and have manageable side effects. Subsequently, as you can see in this slide, the primary endpoints were progression-free survival, how long patients live without cancer worsening, overall survival. Moreover, secondary endpoints include objective response rate, PD-L1 as predictive biomarker, safety, and side effects. Following this, I will hand over the presentation to Chang, who will continue with the next part.
Hello, my name is Chang. Now I will begin my presentation. About assessment, patients were evaluated for response per RECIST 1.1. VFS were measured from randomization to progression or death. PD-L1 positivity were defined as greater than or equal to 5% of tumor cells. Standard for PD-L1, all patients who received at least one dose of the study drug were assessed for safety according to CTCAE 4.0. Oversight, the study followed GCP ICS and were approved by the Ethics Committee. 950 patients, 83% power, Thai error rate of 0.005. PFS were compared using a log rank test, hazard ratio estimated via Koch model, and PFS QS analysis using Kaplan-Meier. Patients were randomly assigned to 3 groups. Nivolumab group 316 patients, nivolumab plus ipilimumab group 314 patients, ipilimumab group 315 patients. The group has similar characteristics. Approximately 60% of patients were less than 65 years, 27.7% were between 65 to 75 years, and 12.5% were greater than or equal to 75 years. About gender, approximately 64.6% male, 35.4% female. Eastern Cooperative Oncology Group Performance Status Score. Most patients had a score of 0, meaning they were fully healthy or had only mild symptoms. 58% of patients were in stage M1C more severe, distant metastasis, while the rest were in M0, M1A or M1B stages. 36.1% had elevated LDH level. 3.6% of patients had brain metastasis. 23.6% had PD-L1 positive status. 31.5% had BRAF gene mutation. After the median follow-up of approximately 12.2 to 12.5 months, the results showed 13.7% of patients in the nivolumab group, 29.7% in the nivolumab plus ipilimumab group, and 16.1% in the ipilimumab group continued treatment. The most common reason for discontinuation were disease progression in the nivolumab and ipilimumab group, while in the combination group, it was primarily due to drug toxicity. Treatment dosage. The nivolumab monotherapy group received an average of 15 doses. The ipilimumab monotherapy group received an average of 4 doses. The combination group received an average of 4 doses of ipilimumab and 4 doses of nivolumab, but 47% of patients continue receiving nivolumab monotherapy thereafter. Efficacy of treatment. The median progression-free survival was highest in the nivolumab plus ipilimumab group, followed by nivolumab monotherapy and lowest in the ipilimumab monotherapy group. Comparison between groups. Nivolumab plus ipilimumab significantly improved PFS compared to ipilimumab monotherapy. Nivolumab monotherapy also outperformed ipilimumab monotherapy. When comparing nivolumab plus ipilimumab to nivolumab monotherapy, the hazard ratio was 0.74, demonstrating the superior benefit of the combination regimen. About PD-L1 positive group, median PFS was similar between nivolumab monotherapy and nivolumab plus ipilimumab, but significantly higher than ipilimumab monotherapy. About PD-L1 negative group, nivolumab plus ipilimumab showed superior efficacy compared to nivolumab monotherapy and ipilimumab monotherapy. About BRAF mutation group, median PFS was higher in patients receiving nivolumab plus ipilimumab, reaching 11.7 months in the BRAF mutated group and 11.2 months in the wild-type BRAF group.
Hello everyone, my name is Han. Now I will continue to present the results. First point, the autistic repulsion rate, which means was the percentage of persons who active tumor skin cancer, is as follows. Nivolumab monotherapy is 43.7%. Nivolumab plus ipilimumab combination is 57.6%, which is the highest. Ipilimumab monotherapy is 19%, which is the lowest. This information means that the combination therapy provides a best tumor response, while ipilimumab alone has a lowest efficacy. Following that, the complete repulsion rate, which refers to the total disappearance of the tumor cell. Nivolumab plus ipilimumab combination is 11.5%. Nivolumab monotherapy is 8.9%. Ipilimumab monotherapy is 2.2%. Next, the average time to achieve a response was similar among all three groups, which is approximately 2.7 to 2.8 months. This finding suggests that's why the treatment efficacy differs. The response time remains consistent across all treatments. Based on this finding, we can conclude the following. First, nivolumab plus ipilimumab combination provides the best treatment efficacy. Second, ipilimumab monotherapy has the lowest response rate. Third, time to respond are not significantly different between groups. Following that, I will present the tumor size trends observed in this study. Tumor burden was evaluated by measuring the sum of the longest diameter of target lesion in each pattern. The approach provides an accurate assessment of how tumor respond to treatment. Nivolumab monotherapy shown in Figure A with the blue color had a median tumor reduction of 34.5%. Nivolumab plus ipilimumab combination shown in figure B with the orange color has a high medication reduction of 51.9%. Ipilimumab monotherapy shown in figure C with the green color had a median increase of 5.9%, indicating poor efficacy compared to the other two groups. This result indicates that the combination therapy provides a more certain tool to more screen case. Next, table 3 shows the treatment-related adverse event. First point, overall indicate of treatment-related adverse event as follows. Nivolumab monotherapy is 82.1%. Nivolumab plus ipilimumab combination is 95.5%. Ipilimumab monotherapy is 86.2%. This result confirms that the combination group had a highest indicated rate of treatment-related adverse event. Second point, grade 3 or 4 with mean severe adverse events. Nivolumab monotherapy is 16.3%. Nivolumab plus ipilimumab combination is 55%. Ipilimumab monotherapy is 27.3%. Third point, most common adverse event at any grade in the nivolumab plus ipilimumab group. Diarrhea is 44.1%, which is the most common. Fatigue is 35.1%. Pruritus as well as itching is 33.2%. This finding suggests that diarrhea is the most common adverse event in the combination group. 4. Discontinuation rate due to adverse event. Nivolumab monotherapy is 7.7%. Nivolumab plus ipilimumab combination is 36.4%. Ipilimumab monotherapy is 14.8%. This result indicates that the combination group has the highest continuation rate due to adverse event. Finally, we go to table 8.3. Table 8.3 requires image-related adverse event. As observed in previous study, image-related adverse event, as known as IRAEs, are classified based on the effect organ system. The most common grade 3 or 4 adverse events include the following. First point, gastrointestinal system. Diarrhea range from 2.2% to 9.3%. Colitis range from 0.6% to 8.7%. This result confirms that the combination group with the nivolumab plus ipilimumab has the highest incidence of diarrhea and colitis. Second point, hepatic system. Elevate ALT level range from 1.3% to 8.3%. This means that the combination group also has the highest risk of elevated liver enzyme, specifically ALT.
Hello everyone, my name is Trần Thị Khánh Ly. I will present the conclusion. In the pre-3 study, nivolumab alone and nivolumab combined with ipilimumab prolonged progression-free survival, abbreviated as PFS, and increased the objective response rate, abbreviated as OII, compared to ipilimumab alone. The effects were often regardless of PD-L1 status, BIAF mutation, or metastatic state. Subgroup analysis suggested that the greatest benefit of combination therapy may be in PD-L1 negative tumor. In PD-L1 positive patients, nivolumab alone and the combination have a similar PFS, but the combination have a higher OIR. From the results, it can be seen that the combination group has the highest rate of adverse events, especially elevated liver enzyme, AST 6.1%, ALT 8.3%, compared to 1 to 2% in monotherapy group. However, legitimate-related deaths were reported, and adverse effects were manageable following treatment guidelines. Conclusion: combination therapy is more effective, but have more adverse effects, which are manageable, making it a safe and viable option in clinical practice. Here are your group reference documents. Thank you everyone for listening to our presentation.